الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين وعلى آله وصحبه أجمعين. Heat and Heat Disorders Clinic by Professor Mahmoud Hani Sulaiman. This is physical hazards, occupational physical hazards that may be encountered in any work. Health hazards due to heat. Health hazards due to heat are heat syncope, cramp, exhaustion, stroke, rash, cataract, edema, and psychological effects. So they are syncope, cramp, exhaustion, stroke, rash, cataract, edema, and psychological effects. Heat balance. Normally, the body is in a state of equilibrium between heat gain and heat loss, resulting in a relatively stable temperature at 37 degrees centigrade. Heat gain occurs through metabolism, radiation, and conduction. Metabolism, radiation, and conduction. Heat loss occurs through evaporation, radiation, and conduction. Evaporation, radiation, and conduction. Body temperature equals M plus or minus R plus or minus C minus E. Conduction is heat exchange between two surfaces in direct contact. It is generally the least important mechanism of heat loss. Convection equal heat transferred from a surface to a gas or fluid. Heat transferred from a surface to a gas or fluid. Radiation is transfer of heat between body and its surroundings by electromagnetic waves. Radiation equal transfer of heat between body and its surroundings by electromagnetic waves. Evaporation equals conversion of a liquid to gaseous phase. Conversion of a liquid to gaseous phase. Evaporation of water takes place from lungs and skin. The body will attempt to unload excess heat gained to maintain a normal body temperature. Body's primary defense against overheating is sweating. 1 liter of sweat, when evaporates from skin, removes 600 kilocalories from body. This figure is summarizing the ways the body of humans lose heat or gain heat. Heat balance mechanisms for human body. Thus, decreased sweat loss by climatic conditions as high humidity and slow air movement impedes heat loss. Only small amounts of heat are lost by radiation or by direct convection transfer to air. Heat is distributed throughout body by convection in bloodstream. Thermal sensors in brain respond to increased blood temperature. Thermal sensors in brain respond to increased blood temperature and send signals to hypothalamus, leading to orders to increase or decrease heat gain or loss. So the center is hypothalamus. Heat loss responses will lead to increased rates of blood, skin, and sweating, leading to increased rate of heat transfer from body core to the environment. When rate of heat dissipation equals rate of heat production, body temperature is stable. Increased body core temperature of more than 2 degrees centigrade to 2.5 degrees centigrade will lead to side effects. These side effects will decrease both ability to prolong activity and performance. This redistribution of blood towards skin. So this will lead to decreased arterial blood pressure, decreased blood flow to brain, leading to feeling of dizziness, disorientation, and loss of consciousness. With occurrence of heat stress, sodium and potassium are lost in sweat. Decrease in renal blood will lead to renin-aldosterone mechanism to conserve sodium, leading to increase in potassium loss. Decreased central blood will lead to increased antidiuretic hormone and plasma osmolality is increased. Notes: adverse health effects of heat stress occur only if heat stress is more than individual's heat tolerance capacity. If heat stress is more than the individual's heat tolerance capacity. After body's core temperature rises, pathologic responses ensue. These are acute hyperthermia, leading to hepatic necrosis and pancreatitis, fibrinolysis and activation of platelet activity, leading to disseminated intravascular coagulation, DIC. Disseminated intravascular coagulation, DIC. Rhabdomyolysis, myocardial necrosis, due to skeletal and myocardial disruption. Decreased renal function due to decreased renal blood and severely disrupted by outpouring of myoglobin and uric acid from this cascade. Ultimately, CNS is affected by heat, DIC, and metabolic disturbances. This figure shows temperature regulation. Increase in core temperature sensed and regulated by hypothalamus, then stimulus via sympathetic nervous system to initiate sweating and increase peripheral blood flow. This is a good summary for physical heat loss, how occur: evaporation, conduction, radiation, and convection. Please print it and study it. This table also shows causes of hyperthermia syndromes. When the temperature rises, the hyperthermia syndromes occurring to the human are heat stroke, drug-induced hyperthermia, neuroleptic malignant syndrome, serotonin syndrome, malignant hyperthermia, endocrinopathy, central nervous system damage. These will go in differential diagnosis of heat stroke. Heat stroke is either exertional or non-exertional. Please print it and use it for differential diagnosis in your clinic. This figure also summarizes clinical features of abnormal core temperature. Clinical features of abnormal core temperature. The hypothalamus normally maintains core temperature at 37 degrees centigrade, but this set point is altered, for example, in fever, pyrexia, and may be lost in hypothalamic disease. In these circumstances, the clinical picture at a given core temperature may be different. So, what are the clinical features of abnormal core temperature? Either heat stroke, the patient is hot and not sweating, at above 40 degrees centigrade. Heat exhaustion between 37 degrees centigrade and 40. The patient is hot and sweating. Heat exhaustion, again, the patient is hot and sweating. Mild hypothermia, the patient is cold and shivering between 35 and 32. Severe hypothermia between 32 and 28. The patient is cold and not shivering. Below 28, the patient will get into coma, absent pupil reflexes may appear dead, loss of corneal reflexes, and cardiac standstill. This is clinical features of abnormal core temperature of humans. Please print and use in differential diagnosis. Differential diagnosis in patients with elevated core body temperature. When it is elevated, the core temperature, heat illness, either exhaustion or stroke, sepsis, including meningitis, malaria, drug overdose, malignant hyperpyrexia, thyroid storm. These are the differential diagnosis in patients with elevated core body temperature. Risks predisposing worker to heat exhaustion and heat stroke, either in those normal or healthy or with diseases. In normal healthy, heat exhaustion and heat stroke may occur due to salt and water depletion, infection, fever, lack of acclimatization, obesity, drugs, which will be given next slide, advanced age. So normal persons, salt and water depletion, infection, fever, lack of acclimatization, obesity, drugs, and advanced age. Predisposing diseases are for heat exhaustion and heat stroke. Predisposing disease for heat exhaustion and heat stroke. Cardiovascular disease, diabetes mellitus, malnutrition, acute chronic alcoholism, electrolyte disturbances, hyperthyroidism, impaired sweat production, miliaria, sweat gland injury after prior heat stroke, cystic fibrosis, scleroderma, healed thermal burns. So those with this disease must not work in heat environment. Drugs that may enhance risk for heat stress induced disorders. So anyone taking these drugs must not work in hot environment. These drugs are alpha and beta blocking agents, anticholinergics, antidepressants, antihistamines, calcium channel blockers, cocaine, diuretics, dopaminergic, ethanol, lithium, neuroleptics, and sympathomimetics. Physiology of heat regulation. Physical activity adds heat to body at a greater rate than does a hot environment. Work activities can range from 80 to 700 kilocalories per hour. This is the rate of heat generation for common occupational activities. So please, any worker in a hot environment, you must calculate them for workers at increased heat environment to see for how long the worker can work in this environment. Heat acclimatization, details given at a separate lesson. Heat stress attenuated by heat acclimatization. Workers must do gradually increased exposures to both heat and exercise on a regular basis over 2 weeks. Only this regular and repeated exposure to heat and activity induce acclimatization sufficient to alter heat tolerance. And it is the core for preventive measures to heat diseases. General points for improving heat acclimatization. Conditioning should include strength, endurance, and skills acquisition drills in warm environment. Delay full participation till minimum conditioning levels are met. Heat acclimatization requires 10 to 14 days. Avoid supramaximal efforts as performance testing in heat, particularly those involving workers with sickle cell trait. Historical practice of fluid restriction to improve heat adaptability or conditioning is extremely dangerous and should never be done. Continued general points for improving heat acclimation. Provide education on heat-related illness to all workers. This should include providing awareness and counseling to at-risk population and their supervisors regarding symptoms and signs of early heat stress dangers and sequelae of heat-related illness, and strategies to minimize risk for developing these illnesses. The importance of staying appropriately hydrated, adequate sleep, avoiding drugs and alcohol, knowing each worker individual limitations, and avoiding exercise in dangerous environmental conditions should be emphasized to all workers and supervisors. Heat acclimatization characters increase cardiovascular fitness, altered sweating occurs sooner, increase sweating rate. These are the effects of heat acclimatization. Sweating occurs sooner, increase sweating rate, increase sodium concentration of sweat, increase renal function, increase glomerular filtration rate. Acclimated workers increase tolerance for heat stress. This fact forms basis for control of heat-related illness. Occupational heat exposure types. Dry heat like ovens, hot humid environment, direct exposure to sun, badly ventilated closed places. Dry heat, hot humid environment, direct exposure to sun, badly ventilated closed places. Principles of managing work in hot environments. This is also important. An assessment of risk done to decrease environmental heat load, decreasing humidity, radiant heat, and air temperature. Screen workers for disease risk to heat illness. Workers well hydrated and ideally less than 40 years. Work rest regimens established from standards to ensure cooling down. Health education to workers on heat illness. First aid facilities should be available. Acclimatization for workers and light clothing to be taken into account. Disorders of heat exposure, mainly heat syncope, heat cramp, heat exhaustion, heat stroke, and heat rash. Heat syncope. Heat stress, especially if added to psychological stress, will lead to vasodilatation of blood vessels, leading to decreased blood pressure of the worker, which will lead to decreased blood flow to brain, then syncope. Management of heat syncope. Place patient in recumbent position to maximize blood flow to brain. Administer salt and water. Rarely requires IV. Further testing or prolonged observation is generally unnecessary. Heat cramp. Definition: painful spasm of voluntary muscles. Painful spasm of voluntary muscles. Mechanism: increased sweating causes loss of water and sodium chloride. Compensation for water only leads to irritability and cramps. Symptoms: usually in abdomen, arms, or legs. May occur with strenuous activity. If worker has cardiovascular problems or on low sodium diet, get medical attention for heat cramps. If medical attention is not necessary, take these steps. Stop, drink, do not return, seek. Stop all activities and sit. Stop and sit quietly in a cool place. Drink clear juice or beverage. Do not return to strenuous activity. Seek medical attention for heat cramps if they do not subside in 1 hour. Heat exhaustion. Warning signs of heat exhaustion include heavy sweating, paleness, muscle cramps, tiredness, weakness, dizziness, headache, nausea, or vomiting, fainting. Again, warning signs of heat exhaustion include heavy sweating, paleness, muscle cramps, tiredness, weakness, dizziness, headache, nausea, or vomiting, and fainting. Clinical spectrum of heat illness. This is heat edema, heat rash, heat cramps, Please print and use. Heat edema is self-limiting swelling of hands and feet resulting from cutaneous vasodilation and dependent pooling of interstitial fluid resolves with early acclimatization. Heat rash, miliaria, pruritic red vesicles found on skin covered by non-breathable clothing or sleeping pads. Occlusion of eccrine sweat ducts by keratinocytes leads to dilation and rupture. Secondary infection with bacteria including methicillin-resistant Staph aureus in common. Repeated occlusion of sweat ducts results in progression of inflammation and if untreated will lead to chronic dermatitis. Heat cramps, as we said before. Heat tetany, hyperthermia associated with hyperventilation causes primary respiratory alkalosis, which in turn can cause perioral paresthesia, carpopedal or laryngeal spasm and Chauvet-Stokes sign, heat exhaustion and heat stroke. As we said, danger symptoms include nausea, vomiting for heat exhaustion, nausea, vomiting, fatigue, weakness, and occasionally diarrhea. Clinical findings include orthostatic hypotension, tachycardia, syncope, hyperthermia, core temperature less than 40 degrees centigrade, and minor mental status changes as poor attention span. Caution, heat exhaustion and heat stroke have overlapping symptoms. The primary differentiating criteria is that heat stroke is associated with more severe CNS disturbances and core body temperature more than 40 degrees centigrade. Heat stroke is a life-threatening condition. Heat stroke is a medical emergency characterized by core temperature more than 40 degrees centigrade and CNS disturbances in patients with a history of heat exposure, anhidrosis, absence of sweating. Heat stroke, anhidrosis, absence of sweating, is often present but is no longer criteria for diagnosis. Heat stroke occurs when thermoregulation fails completely, leading to organ dysfunction and death. Caution, heat stroke is often missed in patients who may not have been physically active. Lab assessment of heat illness. In mild cases, obtain urine analysis, test for pH, specific gravity, urine sediment, and hemoglobinuria and myoglobinuria. In moderate cases, add basic blood chemistry, test for sodium, potassium, chloride, bicarbonate, blood urea, nitrogen, and creatinine. In severe cases, when CNS disturbance is present, add AST, alanine aminotransferase, lactate dehydrogenase, uric acid, calcium phosphate, coagulation studies, PT and PTT, fibrinogen. Consider arterial blood gas for accurate determination of physiologic pH. Differential diagnosis of heat exhaustion and heat stroke. For heat exhaustion, body temperature is less than 40 degrees centigrade. For heat stroke, it is more 40 degrees centigrade. Dermatologic findings, sweating for heat exhaustion is present. Heat stroke, little or no sweat. Treatment of heat illness. For all, they must have rest, hydration, electrolytes, access to cool place, initiate rapid cooling for temperature more than 40 degrees centigrade, and any patient with mental status changes. Heat edema, elevation of legs, cold compresses on arms and legs or cold baths. Heat syncope, move to cool location, rest and fluids. Heat syncope and dehydration, electrolyte replacement, consider discontinue antihypertensive and anticholinergic medications. Heat cramps, rest, hydration and electrolytes. heat tetany with hyperventilation, move to cool environment, restore normal respiration rates. In severe cases, rebreathing carbon monoxide or use benzodiazepine. For heat exhaustion, as above, provide oral or intravenous hydration, mist water convective cooling, and focal use of ice packs on large superficial veins, axilla and inguinal regions. Heat stroke, rapid cooling is the priority. Use cold water immersion with rectal temperature monitoring. Patient should be removed when rectal temperature reaches 39 degrees centigrade. Patients with coronary artery disease may develop coronary spasm with ice water immersion. Patients with coronary risk factors should be treated less aggressively with mist water and convective cooling. This figure shows thermoregulation and therapeutic cooling for patients. Because heat stroke is an emergency, I will explain the treatment again. For heat stroke, get victim to a shady area, cool victim rapidly using whatever methods, e.g. immerse him in a tub of cool water, place him in a cool shower, spray him with cool water from a garden hose, sponge him with cool water, or if humidity is low, wrap him in a cool wet sheet and fan him vigorously. Monitor body temperature and continue cooling efforts until body drops to less than 40 degrees centigrade orally. Transfer immediately to ER. Continued heat stroke treatment, cardiovascular airway support, effective ventilation after IV line baseline studies. Rapid body cooling, spraying naked patient with cool mist while using fans to enhance airflow over body, leading to decreased temperature by 0.06 degrees centigrade to 0.116 degrees centigrade per minute. Shivering is treated by phenothiazine, acid base, electrolyte disturbance corrected. Renal function must be optimized and treat complications. Heat rash, defined as skin irritation due to excessive sweating during hot, humid weather. It occurs at any age, but most common in young children. Sweating in dusty environment leading to closure of sweat gland duct, then sweat forces upper dermal layer of skin leading to formation of vesicles. Heat rash diagnosis. Heat rash looks like a red cluster of pimples or small blisters. It is more likely to occur on neck, upper chest, groin, under breast, elbow creases. Heat cataract, glass worker's cataract, starts in posterior cortex of lens, forms a web, leading to a regularly shaped discoid posterior opacification. Exposure-inducing heat cataract, history of prolonged or reported exposure to infrared radiation emitted by incandescent glass or metal over 500 degrees centigrade. Minimum duration of exposure 1 year, maximum latent period 15 years. وفي النهاية أقول الحمد لله and thank you for your good listening.